And now we are very happy that we have from Vienna, Ursula Wiedermann Schmidt. She is not only a clinician and immunologist at Vienna University Hospital, she's also part of the German system in the STIKO, the Permanent Vaccination Committee in Germany, so that we always have intense exchange with the Austrian colleagues. And Ursula, we are very happy to have some more clinical perspectives, because we were discussing a lot of immunology today, but at the end of the day, it's really the question, how does this relate to the clinical aspects? And this is what your talk is all about. Thank you.
Thank you very much, Christina, and thank you, Andreas, for inviting me here. I'm very happy to be in that exciting day with you. Well, I would like to start with this lady here. She was actually the first lady being vaccinated in Austria with the mRNA vaccine when we got them. The reason why she got this was, of course, because of her age. She was 90 years old. And as you know, in nearly all countries, there was a clear prioritization list who should be vaccinated first, due to the fact that aging people, but also other groups that are listed here were at particular risk for severe COVID and death. And apart from the age, it was also people with high BMI, obese people, all types of immunocompromised people, and among these cancer people who had particularly high death rate. Now, the questions or the topics I want to discuss is, even though these people are at a particular need for vaccination, the question is, or was, if they will respond well enough to the vaccine. And so our question was, how is actually the response rate or the non-responsive rate to vaccination, and who was mostly affected and why? The question in general in our practice, what can we do against? And finally, I just want to touch very shortly if we find any markers for the opposite, namely increased reactogenicity to vaccination, and who is affected there. Now, we have in Austria at the Medical University now since 10 years run an outpatient clinic for vaccination, where we concentrate on risk people, on frail elderly people, and all sorts of immunocompromised people. And this was, of course, with COVID, then a chance to really start different cohorts and follow them up for 5 years or 4 years of vaccination. And this is what I would like to shortly tell you on 3 examples: elderly, obese, and immunocompromised. And our question was really, is there a level or what is the level of non-responsiveness in these risk people, and do we find a common pattern for non-responsiveness? Is there some sort of common denominator that we can find and have as a sort of prediction for non-responsiveness? Well, here from other studies, it is clearly has been shown that the outcome to an infection was, of course, much improved if elderly people were vaccinated, as you can see here, in terms of hospitalization, intensive care, and oxygen administration. But this study also clearly showed that it was not only the vaccination status that had an important effect on the outcome, it was also the quantity and quality of the immune response in terms of antibody levels they looked at, and showed when those elderly people that were not able to mount sufficient antibodies were those who were of higher risk for mortality, even in the Omicron season. Now, since we have this outpatient clinic, the question of how well do elderly people respond to primary vaccination before COVID was not so easy to answer, because most of the vaccines have been given early in life, and there was nearly no vaccine that gives a primary vaccination in elderly. Only one example here is possible, taking travel vaccines as the one against Japanese encephalitis. Here we could really compare elderly people stable with young ones in terms of response to the vaccine. And you can see here clearly that the elderly could respond, but with a clear, much lower antibody level rate than the younger ones. And if we looked here more closely to the non-responder rate and low responder rate, you can see that nearly 46 or 47% of the elderly did not properly respond to the vaccine. Of course, of interest was how is this associated? Do we find other parameters when looking here on the T cell level? And what was shown here, what we could see is that there was in the elderly a clear shift towards Th2 responses to the vaccine, and this was also associated with higher rates of regulatory cells. And fitting to the talk before, we also saw that those who had been a CMV infection in previous time and were seropositive were the ones that did not get good antibody levels. And of course, the number of people with CMV infection was much bigger in the elderly than in the younger ones. Then when we did the COVID vaccine trials, here's one example from the controls where we, in a subgroup, looked at the primary vaccination. This was after two vaccines, mRNA vaccines, and looking at the response over a period of 6 months. And you can see clearly here this association, the older the people are, the stronger the fold decline of antibodies are within 4 to 6 months, 4 weeks to 6 months after primary vaccination. And this was also seen in other studies where you can see here the comparison between elderly and a younger one with regard to antibody responses, but also with respect to memory responses. So they don't have that amount of memory cells. And within this line, there was a very nice publication showing what could be the hypothesis of non-responsiveness in elderly. And we have seen from Marieke today already very nice data, but this is along the line that actually there is no really defect in the extrafollicular responses for elderly. They do have B cells that are non-defective, and they can differentiate into plasma cells, but in general, the immune responses or the cells are short-lived plasma cells, and they have definitely lower antibody levels. But the real problem is within the terminal center formation, which does not work in the with aging anymore. So there is a clear problem in antigen presentation here on the border between dendritic cells and T cells. There is an decreased migration of T cells, but increase on regulatory cells with altogether hamper here the formation of a terminal center and long-lived plasma cells to a new antigen, to a primary response. Now, the second group of interest were the obese one, and the question is, do we find similar parameters here? Because in the aging people, the inflammation is an issue, but also in the obese, this is a big issue. And you can see here that the adipose tissue is really like a hormone producer where leptin is produced, but also different cytokines like IL-6 that activate macrophages. And by this, you get a constant inflammation response with C-reactive protein from the liver. So altogether, there is a chronic low-grade inflammation in obesity. And the question is, how does this look for into a vaccine response? Also in the pre-pandemic era, we just had the possibility to look at vaccine responses. In this case, it was a TBE, tick-borne encephalitis vaccine, but a booster vaccination, because in Austria, all people are vaccinated. This is one of the vaccines they really love in Austria. So 90% of the elderly are vaccinated. So we could only look at booster responses here. But what was clear that the metabolic parameter, they have increased increased like insulin level, leptin levels, but also increased CRP levels, that there is a clear inverse reaction to the kinetic of the antibody responses. While after booster vaccination in the beginning, there are good antibody responses in the obese, there is then a fast and early decline of antibody levels. And this is somehow related to the fact that obese people do have increased numbers of B cells, in particular naive cells, but definitely lower amounts of unswitched and switched memory B cells. And the question here is this low-grade inflammation also a reason why no germinal center will develop? Looking at also a subgroup of the controls in our trial on primary vaccination to COVID actually looked similar as TBE. So the first responses of the two vaccines were comparable between obese and non-obese, but what was clear was again an increased decline of antibodies within a period of 6 months. So as we didn't have a whole clinical trial on obesity, we went in our mouse model of obesity and looked here how a primary vaccination looks like. And we see here that actually the primary vaccination already starts with lower vaccine responses compared to the lean mice. That here, when we looked at the specific memory B cells, that they were significantly lower, and also T regulatory cells, on the other hand, were increased. So the question, would this be similar as we have seen in the other groups? Is this somehow related to decreased germinal center formation? And the first indications here from histology is the case that lean mice do have bigger germinal center formation than here the obese mice, but currently we are in the middle of doing single cell RNA sequencing and to see really what is the case and how does germinal center formation and the cell populations look like. So this I have not yet. The third group, the immunocompromised ones, here we have had 3 cohorts going on in parallel. Cancer people, myeloma patients, and intestinal bowel disease. And following up with Marieke, I just want to show you here our results, which are along the lines like you saw already, that actually in IBD patients, that the primary response after 2 vaccinations did not differ very much from the healthy controls. But what was here obvious is that there was a clear decline after a period of 6 months compared to the healthy controls. You can see that they are all kept more or less in protective levels. But here you can see that there is a certain number of patients who lose their antibody levels. And when looking according to their therapies, it was particularly the anti-TNF treated patients that lost earlier their antibodies, so where antibody waning was prominent. And here you can see the comparison. The red line is the anti-TNF treated who really have lower antibody levels and earlier waning compared to patients, for instance, who are treated with vedolizumab, with integrin. They respond as good as healthy controls. So it really has to do with the anti-TNF, and also these anti-TNF treated patients don't respond with any neutralizing antibodies against other virus of concern. In this case, it was Omicron. So when looking at the memory cells, there was a clear difference between vedolizumab and anti-TNF treated. And you can see here the vedolizumab, they really responded with memory B cells and very nice antibody responses. But here the anti-TNF did not show any memory cells, no antibody levels, but a very high number of plasmablasts. And the question here was if this is related, and we have heard the answer from Marieke, actually, that actually under inflammation, there is really a disturbance in production of germinal centers due to so in particular TNF and other pro-inflammatory cytokines. So the follicular helper cell are blocked to migrate into the germinal center, and this is exactly what we also saw in our vaccinees here, the low responder compared to the responders who didn't show any follicular helper 1 cells formation. So just to sum or to repeat more or less what Marieke showed much more sophisticated than me now, is that we do believe that here is primarily the possibility of having the extra follicular responses, but obviously under anti-TNF, this formation of germinal centers is inhibited. So what can we do now against this? Actually, we face this, and for us, one of the most important things is also that if we categorize different patients, it is really important not only to look at the group of autoinflammation or the group of cancer people, but really define more clearly what therapy they get, because there might be big differences in their response possibility, and also in the question whether they shall be more often vaccinated. And indeed, repeated booster vaccinations did help a lot. And this is the example from our multiple myeloma patients, where we could show that their response was actually delayed. So they had to have at least 3 to 4 vaccinations to build up memory B cells and antibodies. And if these were additionally then infected, there was really a boost in the formation of memory B cells and good responses. So the influence of the antigen, the number of antigen contacts, probably also a difference from really the infection with the virus, made it possible to overcome this immunosuppression in multiple myeloma patients. And here is just to show you all the 3 cohorts: the solid tumor, multiple myeloma, and inflammatory bowel disease. We have followed them up with 6 vaccinations up to 4 years. And you can see really that with each booster vaccination, that the decline rate is in all immunosuppressed patients improving with time, which is to say one possibility how to overcome this non-responsiveness. And this has been very recently also published with a prediction model where the authors came more or less to the same conclusion, that in age or in immunocompromised patients, probably it is necessary to have an annual or even semi-annual booster vaccination in these high immunosuppressed patients to get protection and prevent the risk for severe COVID. Other possibilities we have, not so much now related to COVID, but in general, I mean, fortunately, there has been really a series of different adjuvant systems newly developed in the vaccines we have today. And in particular, those vaccines that work via toll-like receptors or here CpG or a combination of both are the ones that are helpful for vaccines in elderly and in immunocompromised. And you can, oops, sorry. This was a little bit, and you can see here that really the more sophisticated adjuvants, like for instance oil and water emulsions, help to have better responses in elderly populations. One can also think, and this is more still in the development side, but I think very interesting and important here is the question whether blockade of low-grade inflammation or the blockade of suppressive cytokines might help. And here it has been shown with rapamycin being given in elderly before they were vaccinated with influenza, which actually really showed improvements in it. And this is at least a thought and a way that might be possible in vaccines against really severe diseases to have possibilities to interact with this low-grade inflammation. And the same would be with IL-10 blockade or with checkpoint inhibitors like IL-10. We see this in cancer patients who are under anti-PD-1 treatment, that they do respond very well to co-administered routine vaccines. And the platforms, of course, are a new development. I think that we all agree that the mRNA development has been really a milestone for, in particular, those patients who are at risk of non-responsiveness. But here is an example also for other possibilities to overcome non-responsiveness. In this case, it's hepatitis B non-responsiveness, which is, of course, totally different. Here it's HLA-related non-responsiveness, but here, a colleague of us, Rudi Volento, you all know him. He has done a new construct of a pre-S recombinant vaccine against hepatitis B, and really shows that a different a modified antigen and delivery system will help in those people who are non-responded to the hepatitis surface antigen. And finally, biomarkers in the, so to say, when you deal with these patients, you would like to have prediction markers for those who cannot respond, to know from the very beginning, shall you have another vaccine taken, shall you do other schedules? And here, biomarkers that might be helpful are the biomarkers that indicate this low-grade inflammation, like IL-6 or CRP, which has been shown here in the study, or to look, and this is what we more or less routinely do meanwhile with together with Wilfried, that we really make an immunoprofiling by patients that are being already on therapy and have been long on therapy, because here we get then the clear indication, does it how do the B cells look like T cells? Can we expect to have a vaccine response, a proper vaccine response? The last thing I just want to mention, we had just started with this also together with Winfried, is the question, are there certain prediction markers for hyperreactivity? We have not touched at all the topic of extreme reactogenicity to vaccination. I, in my outpatient clinic, have been very much had to do with these patients. We had more than 200 patients coming with really severe side effects, not only to the infection, but also to the vaccine, mostly in combination. And so what in the first little analysis, which we now started, is that mannose binding lectin deficiency is really a risk factor, obviously, for those people have developed long COVID after infection, but also they develop similar symptoms when they get vaccinated. In particular, when they had several mRNA vaccination, they developed very similar issues. So 66% of this MBL deficient patient developed this hyperreactogenicity. So I think that is also for us in the practice some parameter that might be included in the immunoprofiling as we do this in our patients. Yeah, and with this, we have more or less put a roadmap for immunocompromised patient, how to go along, what is the best to have the best treatment for them. Of course, we start with an intensive medical history, the vaccination status, which includes the antibody titers against all different vaccines, but also looking at the vaccine responsiveness in like a diagnostic vaccination or immunoprofiling, because this is then the information for the decision of what vaccine type and what schedule to use. And parallel to this, we continue our cohort studies to get more information and guidance for the future, how to monitor and treat this immunocompromised patient properly. And with this, yeah, this is the most important. This is the team. You can see mainly ladies team. There are two brave men we have in our institute, but mainly it's the females here, Nora Geisler and Erika Ganner-Spitz, who are working on obesity. Angelika Wagner, who is doing the clinical trials, and here Ines Zwatzl, who is the head of the clinical trial setup in our institute. And with this, I want to thank you very much.
Thank you very much, Ursula, for this great insight into your clinical view. and how all the immunological details make sense in a clinical setting, and the benefit of having an outpatient unit with a history so that you compare the pre-pandemic and the pandemic era. And I think this is really, really extremely helpful. And it supports the decisions of STIKO and others why there are patient groups who really should be vaccinated repeatedly. Absolutely. Are there questions? Andreas.
It wasn't quite clear to me from the slides to what extent actually the reaction to boosts in this repeated boosting, often repeated boostings of the frail individuals, to what extent it was correlating to pre-existing antibody titers. So there is this feedback inhibition of antibodies existing already. So they had very low antibody titers. Then they were boosted, and then antibody titers went up.
Yes. So
it was down back to the same level they were before.
Yeah? But this was in the beginning. So this was up to 4 vaccines that they usually lost within 6 months. And then with the 5th and 6th vaccination, they just kept higher levels even after a period of 6 months.
But they reached a plateau, or they didn't continue.
They did not reach really a plateau. It was developing constantly, but then they ended up with some plateau, like the controls. They also reach a plateau where they don't become better anymore. But at least what was important, they didn't lose the antibodies below detection level, and that was only reached by several boosters.
And this was the immunosuppression was certainly something that was sort of the underlying condition.
Yeah.
Special kinetics. Mareike.
Very, very wonderful data. I was wondering, I think in the multiple myeloma you showed that it took longer for patients to get there. Any idea what the reason behind that was?
This was, I didn't tell the whole story. So this was mainly the patients that were under anti-CD38 treatment, and so they needed some time really to be able to build up response. But in the beginning, they took a long time before they could respond with antibodies. But happily, they converted.
So my last short question would be, you showed in the obese population the idea that the germinal center reaction is impaired, and this is part of the impaired response. Is there anything known about ex-obese individuals who return to a normal BMI?
A good question. No.
The question whether this could normalize again, because that might be a population that is coming
now
with the new drugs. That might be a population to study.
That would be very nice, really, to compare these populations. No, we have just started with.
So thank you very much. I think we have a lot to take home with